Well, thank you, Dr. Berman. That was terrific. It's wonderful, and I think it's going to be complemented in a great way by Dr. Chinazo Cunningham's talk. And let me briefly introduce Chinazo. I also need a guide here because she's incredibly accomplished. She's a professor of medicine, family and social medicine, psychiatry, and behavioral sciences. She earned her undergraduate degree from Northwestern, and I'll come back to that in just a minute. Her MD from UCSF, and I was at UCSF for a while as well, and her master's here at Einstein. She interned at San Francisco General Hospital, and I have many fond memories of the General, and was subsequently a resident and chief resident in internal medicine at NYU, and she joined the faculty here in the late 90s and holds a number of leadership roles at the college, including the Director of Diversity Affairs and Internal Medicine, the Associate Chief and Director of Research Resources in General Internal Medicine. She's a director of the GIM Fellowship Program, and she served on numerous national advisory committees, serving as the chair of New York State Department of Health AIDS Institute Substance Abuse Committee, a member of the Opioid Guideline Work Group of the CDC, CDC's guidelines documents for prescribing opioids for chronic pain. She's a member of the NIH Office of AIDS Research, AIDS Research's Racial and Ethnic Populations Committee, and a member and the chair of the NIH Behavioral Social Consequences of HIV/AIDS Study Section. She's exceptionally well-funded from the NIH, the CDC, HRSA, including an NIDA grant on the topic of today's talk. She's been a leader in developing programs, conducting research, and providing care focused on marginalized populations, including people who use drugs who are at risk for HIV and infection. We have a few things in common. We both spent some time in San Francisco. We're both here at Einstein. And we were both college athletes, although she was much more accomplished than I was. We both played baseball in college. Chinazo was a Big Ten all-conference player, academic All-American, batting champion. I spent 2 years riding the bench in Buffalo and figured I better be good at something else because this is not going to be a career path for me. So it's a real delight for me to introduce Dr. Chinazo Cunningham. She's going to be talking about changing the paradigm, treatment of opioid use disorders with buprenorphine in primary care. Chinazo.
Great. I'm very honored to be here today to talk to you about something I'm very passionate and to also share my talk with Joan Berman. So my talk has 3 acts. One is getting to buprenorphine. The second, Act 2, is buprenorphine treatment, and Act 3 is after buprenorphine. So my path is pretty untraditional and nonlinear. Before I even came to Montefiore and Einstein, I had 2 young children. I had my first daughter as a third-year resident and my second daughter as a chief resident. In my second year as a faculty member here, I then had my third daughter. So as you can imagine, having 3 young children closely together created some challenges for my career. That's why for the next 6 years, I toggled back and forth between working part-time and full-time. 8 years into my career, I decided I needed additional skills and knowledge, and then went back to school to get my master's degree here in the clinical research training program in clinical epidemiology to learn skills for research. And then, after that time, I transitioned from becoming a clinician educator to a clinician investigator. So while this is non-traditional and what appears to be nonlinear, there are many guiding principles that have really been along throughout my whole career, which I'm going to talk about. So I'm sure you're familiar with this map, Manhattan, and you see the Bronx. And it's really the Bronx that I was attracted to when I took my job here at Montefiore and Einstein. And it was, in particular, my clinic, which is noted with this red arrow in the South Bronx. So my clinic is the Comprehensive Healthcare Center. And this clinic is located in one of the poorest neighborhoods in the country. It's actually part of the poorest congressional district in the United States. So the need is tremendous. And this is really where I wanted my work and my impact to be, in the place where it was needed the most. So when I came here to Montefiore and Einstein, we were experiencing the HIV epidemic. And so this is a graph that shows the HIV epidemic in New York City from 1981 to 2016. So this red line is new AIDS diagnoses, the green line is HIV-related deaths, and then the bars are people living with HIV and with AIDS. So when I went to medical school in San Francisco, my experience was very much through the lens of HIV. So people were dying and we had very little treatment to offer them. When I came to New York for residency, there was vast improvements in HIV. And so you can see that deaths decreased substantially. And that continued through my career here at Montefiore. However, as you know, advances in medicine are not equally distributed. And in fact, most of the patients and most of the community members where I worked in my clinic did not reap the benefits of these advances. So in 2000, there was a report that the New York City Department of Health put out about premature death according to New York City neighborhoods. And relative to all New York City neighborhoods, the Bronx had higher rates of premature death. And the neighborhood that had the worst premature death was the neighborhood of Highbridge and Morrisania, which is where my clinic is located. What was driving this premature death? Number one was HIV and AIDS, and number two was substance use and overdose. So what did I do? So I started to collaborate with a community-based organization called Citywide Harm Reduction that was located about a mile away from my clinic. So Citywide served people who were HIV infected, using drugs, and homeless, and provided harm reduction services. We would go and do outreach in the evenings to single-room occupancy hotels. So these are hotels where people who are HIV infected and are homeless and using drugs live. We would go door to door in these hotels, so I went door to door once a week for 10 years, while pregnant also, looking to see what people needed. Did people need services? Did they need a medical doctor? Did they have any medical questions? Did they want to come in and see us? And while I was doing this outreach, I clearly recognized the need to develop a real program because I personally couldn't do this. We really needed a team of people. So we developed the Health Services Program, which was a collaboration between Montefiore and Citywide Harm Reduction. And while I was working on this program, and this program was expanding, I then realized we needed to conduct research and evaluation and to find out how the program was working and how we could best deliver services to get the best health outcomes for the patients that needed it. So from this, we published many studies that basically showed providing care in hotels, providing care in Citywide's drop-in center, and providing care in our clinic could meet the needs of these patients. And so one of the themes throughout my career is we see people in the healthcare system who make it into our system, who make it into the walls of the clinic and make it into the walls of the hospital. But in fact, the most marginalized are those people who never make it there. And part of what I've been interested in working on is how do we get those people into our care, the people who need us the most. While this was happening, this is what this country was experiencing, the opioid epidemic. And this is a graph that shows opioid-related overdose deaths here in the United States. This was my time as I was working with Citywide Harm Reduction, and what's really important to note here is the change in the landscape. In 2002, buprenorphine received FDA approval for the treatment of opioid use disorder. And that brings me to Act 2, buprenorphine treatment, so developing my lab. So I want to take a step back for a minute and talk about opioid use disorder, also known as opioid addiction. So first, opioid use disorder is a chronic medical condition. There's no cure. It requires lifelong management, and most of the time that requires medication. Our treatments are pharmacologic and non-pharmacologic treatment. And by non-pharmacologic treatment, I'm talking about detoxification, also known as detox, rehabilitation, known as rehab facilities, residential facilities, outpatient drug treatment programs. The data really are not there to support non-pharmacologic treatment. We only have 3 medications that are FDA approved in this country for the treatment of opioid use disorder, and the most commonly used medications are buprenorphine and methadone, which you heard Joan mention. So they're really quite different, both pharmacologically and in the way that we deliver treatment. So I'm sure many people in this room have never been to a methadone clinic, but Montefiore has 5 of them, and Montefiore has the 2nd largest methadone treatment program in the state of New York and really one of the largest in the country. But the way that methadone is delivered very difficult, can be very difficult for patients. It's highly regulated both at the state and the federal levels. It's very often marginalized and away from the way that traditional medical care is delivered. And so people typically have to go to methadone clinics 6 days a week. Buprenorphine is fundamentally different, and it has to do with some of its pharmacologic properties. It's a partial opioid agonism as compared to a full opioid agonist. And because of that reason, it's a much more safe medication, and there's a lot less risk of overdose. And then because of that reason, it can be used in any setting, so it can be used in the primary care setting. And this is really a game changer here, because never before in our history in this country did we actually deliver treatment for substance use in primary care. It's always been marginalized and away from traditional care. So now, with the FDA approval of buprenorphine in 2002, we had a new opportunity. I also want to make the point about the huge gap that we have in treatment. So over 22 million Americans have a substance use disorder, and only 12% of people get treatment. And even of this 12%, many of the treatments are not medications, so they're not evidence-based. So could you imagine in this country if only 12% of people who had heart disease or cancer or diabetes got treatment? We would be outraged. But with substance use disorders, it is fundamentally different, highly stigmatized and marginalized in this country. So to address this gap, we developed Montefiore's buprenorphine treatment program. So 15 years ago, we got funding from the Health Research and Services Administration to integrate buprenorphine treatment and HIV treatment in primary care. We started very small, so 1 clinic, my clinic, with 3 physicians, myself and 2 colleagues. I know one is here, maybe both, and 1 pharmacist. In our first 10 years, we expanded dramatically to treat over 900 patients, and going from 3 physicians who were prescribing buprenorphine to over 25. More recently, we've expanded even more. So now instead of just providing buprenorphine treatment in 1 clinic, we have 6 clinics scattered throughout the Bronx that provide buprenorphine treatment for opioid use disorder. And the way that we have modeled our care is as follows. So within each clinic, we have a physician champion. Then we have a treatment coordinator who's a pharmacist or a nurse. We have a naloxone coordinator. So naloxone is used to prohibit opioid overdose deaths. And so this is obviously an important intervention for patients and their family members. And then we also have community health workers who work in the community to provide education and to help people access care. And then finally, in each of the clinics, we have many, many prescribers who offer buprenorphine treatment. So this buprenorphine treatment network has essentially functioned as my lab, right? It's very different as a clinical researcher than a basic science researcher where you have a physical lab, but really this buprenorphine treatment and this buprenorphine treatment network has functioned as my lab. So I'm going to talk about some of the key research findings that we have in our work. So 2 important questions is, why should buprenorphine treatment be integrated into primary care? So this is fundamentally different than the way that addiction treatment has been delivered for decades. And then, why isn't buprenorphine integrated into primary care? So we've shown that by integrating buprenorphine in primary care, there are improvements in HIV and hepatitis C treatment outcomes, and also improvements in neuropsychological function. So just to start out in terms of looking at HIV, so we were among one of the first sites across the country that started integrating buprenorphine and HIV treatment in primary care. We were involved in a multi-site study. There were 10 sites across the United States. And we followed patients who were initiating buprenorphine treatment and who were HIV infected. We followed them for a year. What we found is that buprenorphine treatment retention, so being on buprenorphine at least 3/4 out of a year, improved antiretroviral treatment with HIV. And so you can see this on your left. The dark bars are those who were on buprenorphine for 3 or 4 quarters. The lighter bars are those who were not retained on buprenorphine. And you can see that those that were retained on buprenorphine had higher rates of antiretroviral treatment. Similarly, in this graph, you have HIV viral load suppression, and you can see similar findings that those who were retained on buprenorphine treatment were more likely to have viral load suppression, so better HIV outcomes. We had similar findings when looking at hepatitis C treatment outcomes, and this was a study that was led by Dr. Brianna Norton, one of my colleagues at my clinic. So similarly, we looked at people who were retained on buprenorphine treatment versus not. Those who were retained on buprenorphine treatment are in blue, and those who were not retained are in the bars in red. And what we see is improvements in hepatitis C referrals, hepatitis C evaluations, offering of treatment for hepatitis C, and initiation of hepatitis C treatment. What about neurocognitive function? So we've heard a lot from Joan about why we might expect improvements in buprenorphine treatment, and in fact, that's what we found. So in this study, led by Dr. Julia Arnsten, we examined how buprenorphine treatment affects neurocognitive function. So we measured neurocognitive function prior to initiating buprenorphine treatment and then 6 months later. And what we found was that greater adherence to buprenorphine treatment was associated with improvements in learning, in memory, and in global neuropsychological function. So clearly here are areas in which we can even collaborate more and more with basic science. So given that we see these improvements, and so I just walked you through a couple of our findings, but we see a lot of improvements in terms of HIV, hepatitis C, buprenorphine treatment outcomes, neurocognitive functions. Why then isn't buprenorphine treatment more widely integrated into primary care? And there's a couple of reasons I want to focus on. So one is the national treatment guidelines, and the other is our studies that actually identify barriers to treatment. So first, when buprenorphine treatment came on board in 2002, national treatment guidelines were developed by a group of experts. And the guidelines were really based on consensus rather than data. So one of the main guidelines recommendations was to have office-based inductions. So what are inductions? This is when we initiate buprenorphine treatment. And because of the pharmacologic properties of buprenorphine, there are challenges to initiating treatment. What the national guidelines said was that this induction process should happen in the clinics, so in the office. They should be observed by medical providers. And basically, patients would spend many, many hours in a clinic with their dose titrated up on buprenorphine. This is very challenging. It's challenging for patients. So 25% of patients will drop out of treatment at this point of the induction, but it's also very challenging for clinicians and for busy primary care clinics. So this was not based on data, and we said, why do we need to have our buprenorphine induction occur in this way? Why can't we have additional strategies? And so we developed a home induction kit, and that included buprenorphine, other ancillary medications to treat opioid withdrawal. We developed an instruction sheet, and then we taught self-management of chronic diseases. And then we studied this. So what did we find? So we followed our patients for over 6 months for those who got home inductions versus office-based inductions. And we found a similar reduction in opioid use. So in this graph here, we have opioid use and time. In the white bars are the standard office-based inductions, and in the black bars are the home-based induction. And you can see, in fact, if anything, home-based inductions did a little bit better, but it was not statistically significant, so there were similar findings, but certainly not worse findings. Then, when we look at any drug use, we actually found that those who had home-based inductions were less likely to use any drug than those who had office-based inductions. So this really changed the paradigm and actually changed national treatment guidelines that have been revised since then. So this is now the standard of care in all of our clinics and in many other clinics across the country. It reduces barriers for our patients, it reduces barriers for the providers, and it's really practicing evidence-based medicine. Another example of the treatment guidelines is that the guidelines cautioned providers against treating patients with opioid use disorder and polysubstance use in primary care. So the thought was that these are complicated patients and they need to be seen in more subspecialty drug treatment programs. I can tell you, we work in the South Bronx in a community that has a lot of polysubstance use. These guidelines basically would exclude all of the patients. We would have nobody to treat. And again, these guidelines were not based on data, but based on theory and consensus. So we wanted to study this. Do patients who use cocaine and have opioid use disorder do worse than those who don't use cocaine? And what we found was similar treatment outcomes. So in this here on the left, we looked at treatment retention over time. Similarly, the bars in the white are those who do not have cocaine use, and the bars in the black are those who have cocaine use, and you can see that treatment retention over time was similar between both groups. In addition, we looked at opioid use, and again, opioid use was similar in both groups over time. So we don't exclude patients who have cocaine use, or cannabis use, or alcohol use. We treat them. And these are the patients who actually need our treatment the most. So in addition to the treatment guidelines, what are some of the other barriers? So we've published a couple of papers on this, looking at barriers to buprenorphine treatment from the perspective of the providers. And one of the things I want to say is so much of the research that happens in this country on medical illnesses really focuses on the individual patients and what's wrong with the patients and how the patients need to change. There's very little that focuses on how we need to change the way that we deliver care, particularly when we're talking about marginalized populations. And so these are some of the barriers that we found with providers. Providers lacked confidence and knowledge about opioid use disorder and its treatment. Buprenorphine requires a special 8-hour training in order to prescribe it, so that was a barrier. Providers felt like they had a lack of access to experts, lack of supportive services, difficulty referring patients to alternative treatment if they didn't do well, and then the induction, as I had mentioned. So based on our findings, we structured our program to address these. So we have incorporated education in the residency curriculum. We provide on-site waiver trainings at Montefiore annually. We have a central way where people can reach us in order to access an expert. So all of these ways are really based on delivering care based on the findings that we find from our research. So Act 3, after buprenorphine. So returning to this graph, despite our expansion of buprenorphine, we still continue to have an opioid epidemic, as we know, and it continues to be a huge problem here in the Bronx. So what next? Well, in 2016, in New York State, medical cannabis became legal. So could this potentially be one strategy to address the opioid epidemic? So we know from prior studies that cannabis has analgesic effects, and cannabis actually helps reduce pain. So could it be used as an opioid-sparing strategy? Right now, 33 states in the United States have medical cannabis laws, and 10 states have recreational cannabis laws, and I'm sure you all know that New York has been in a lot of dialogue about having recreational cannabis become legal here. So in order to examine this, we looked at states that had medical cannabis laws and those that did not have medical cannabis laws, and looked at the potential impact these had, or the association they had, on opioid overdose deaths. So this was a study that was led by Dr. Marcus Bachhuber, who used to be here and recently left. And what we found was that states that had legal medical cannabis laws had 25% fewer opioid overdose deaths than expected when compared to states without medical cannabis laws. So this is a study on a billboard. And this billboard is in many different cities across the country. I do have to say, I never thought my research would be on a billboard. But it's also really galvanized the idea that cannabis can be used as a potential way to address the opioid epidemic. And in fact, it's really informed policies in a lot of states that are considering medical cannabis laws. So similar to the other program for HIV and for buprenorphine, given the potential benefits of medical cannabis, we developed the medical cannabis program, and this is led by Dr. Julia Arnsten. It was established in 2017, 16 physicians here at Montefiore, certified patients, over 600 patients have been certified, and this is, again, integrated into primary care in many clinics in the Bronx. And similar to the other work with HIV and with buprenorphine, we want to study this, again, using our clinical programs as a lab. And so this is currently an ongoing study, a MEMO study, which stands for Medical Marijuana and Opioid Study. And the primary question here is, does medical cannabis reduce opioid use in HIV-positive and negative adults with chronic pain? So it's a cohort study. We're going to be following 250 patients for 18 months, and we're currently enrolling patients and participants. So my lessons learned in my trajectory this far is that, even though getting to buprenorphine has not been straightforward, it's certainly been a way in which I have been able to address the needs of the patients and the community surrounding us in the Bronx, and particularly in my clinic. It's also one way to really address the inequities, both from a programmatic standpoint and a research standpoint, to figure out how to improve access to care, how to better deliver care so that the most marginalized populations can access it and can benefit from it. In addition, I've come to see the lab as a clinical researcher, as our clinical programs, and really leveraging our programs to find, again, the best way to deliver care and to get the best treatment outcomes for our patients. I also strongly believe that our research should be grounded such that we can influence the way we deliver care and influence policy. Changes in the landscape, well, I had no idea that buprenorphine would be FDA approved, and I had no idea that medical cannabis would be illegal in 33 states, really provides for great opportunities to learn and to conduct research. And finally, similar to what Joan had mentioned, all of this work is teamwork. It's teamwork, it's from my family, my husband, my mother, my kids. It's teamwork from our clinical staff, and the amazing clinic, and the nursing staff, and the support staff, the research staff as well, and of course, my colleagues. And I have to say that I say frequently that I think I have the best job in the world. And so much of the reason why I think I have the best job in the world has a lot to do with the people who I work with. I have enormously benefited from incredible mentorship. I've benefited from working with amazing colleagues who are dedicated and compassionate and do some of the most difficult work and bring such a high level of quality both in their clinical care and their education and their research. And finally, one of the things that I'm really incredibly proud of is so many of the people who have graduated from this program have now gone on to other parts of the country leading in clinical care and research and in policy. Thank you.
So I want to thank everybody for coming. These were two terrific talks. Thank you, Dr. Cunningham, Dr. Berman. I want to thank the team that helped organize this, and I want to thank everybody who was involved. I think this is a wonderful example of the complete spectrum of research that's going on here at Montefiore and Einstein. And again, I hope these types of things catalyze more work in other areas of science that I think we can really make major contributions to improve overall human health. We have a bit of a reception outside at the Max and Sadie Friedman Lounge, and I look forward to seeing you there.